Good morning and afternoon, everyone. Thank you so much for joining us for today's webinar on diverse women's experiences with chronic pain and prescription opioid use. I know that people are still joining, but in the interest in time, I think we're just going to get started. My name is Lindsay Wolfson. I'll introduce myself in a bit, but we're so happy to have you with us today. So in today's webinar, you'll notice we don't have the chat box enabled, but any questions you can put into our Q&A. We have Doug and Ella here who are able to support in the back end, and we'll have a whole Q&A period at the end of the webinar. So to get started today, we're going to start with our acknowledgement of both the land and the people that contributed to this work, talk a little bit about the project that's underscoring this work, what we heard and what we found in scoping, review, and interviews, respectively, some of the policy and practice implications and next steps. And we're so grateful. I noticed that there are a few familiar faces. This is the third in our four-part series applying a sex, gender, trauma, and equity lens to substance use. So thank you so much for those of you who have joined us for the previous two, and plan on joining us in 2 weeks for the vaping one. Apologies. So before we begin, we want to acknowledge that we are joining from diverse territories across Turtle Island. We want to acknowledge First Nations, Inuit, and Métis as the first inhabitants and traditional custodians of the land in which we live, learn, work, and play. Today, I'm joining from the traditional territories of the Haudenosaunee, Anishinaabe, Mississauga the Credit, Mississauga, and Wendake-Niuemoisento peoples. Liv is joining from the traditional territory of the Erie, Neutral, Huron-Wendat, Haudenosaunee, Mississaugas. And Ella, who's in the background here, is joining us from the traditional and unceded territory of Lekwungen and Wasanich peoples. We pay respect to the elders past, present, and emerging, and are immensely grateful for the Indigenous and non-Indigenous women who've been a part of this project and share their stories and experiences with us. As I mentioned, my name's Lindsay Wolfson. I'm the research manager at the Center of Excellence for Women's Health, and I helped coordinate this project. Beyond my role as a researcher, I'm also somebody who lives with chronic pain. I am so honored to be joined today by my colleague Liv, another researcher on this project. I'm going to pass it over to them for an introduction.
Hello, yes, my name's Liv. I'm also a researcher at the Center of Excellence for Women's Health, and like Lindsay, I'm also someone who's lives with chronic pain. I've lived with it for over a decade, so this embodiment has really brought a lot of richness to this project, but also something I'm just really grateful to be on this project and to learn and work from it. We also just wanted to take this time to thank our research team for the contributions to this project. It wasn't just the two of us, there was a group of about 6 of us doing this work, so it's been great to do it together. We're also really grateful for the financial contributions for this project, which was provided at to the Center of Excellence for Women's Health by the Health Canada Substance, Youth and Addiction Program. And it's important to note that the views expressed in this webinar do not necessarily represent the views of Health Canada. So pain is one of the most common reasons for Canadians to seek healthcare. 1 in 5 Canadians live with chronic pain. In Canada, the National Pain Strategy was published in 2019 to provide a foundation for a national approach to pain management. In 2020, a second report was issued to reflect stakeholder consultations in the context of both the opioid crisis and the COVID-19 pandemic. Finally, in 2021, an action plan was released that targeted information for healthcare professionals and the public and accelerated knowledge translation and research investments. And that's kind of what brought us here. There's a real need to integrate sex and gender science and sex and gender-based analysis and approaches in all actionable goals, which is what we're trying to do with this work. So this is some research we've done in the past, and chronic pain disproportionately affects women, seniors, people living in poverty, people with mental health and substance use disorders, people with disabilities, and those that have experienced trauma and violence. Women report more chronic pain than men and are more likely to be prescribed and rely on prescribed opioids for its management. sex and gender remain important considerations with prescription opioid use. For instance, the impact of female hormones on pain processing may increase vulnerability to opioid use and misuse, and the susceptibility of side effects. We also know that women who use prescription opioids are also more likely to have high rates of coexisting mental health issues, greater rates of family dysfunction and child welfare involvement, and a higher likelihood of both use and risk of relapse in efforts to cope with chronic pain, trauma, and other life circumstances. Chronic pain for women is related to experience of violence and trauma, along with higher levels of sex-specific chronic illnesses and conditions such as fibromyalgia and endometriosis. The prescription practices of opioids to women are not well documented and may indicate a lack of consideration of sex-related physiological sources of women's chronic pain and gendered factors such as stigma that affect how healthcare providers interact with women. These combined sex and gender-related factors emphasize the different impacts for women with chronic pain, as well as the need for specific approaches for women with chronic pain. Our project sought to explore these sex and gender-related factors. And I'll now pass it on to Lindsay to introduce our project a little bit more.
Thanks so much, Liv. So the aim of this project was really to create sex, gender, trauma, violence, equity, and culture-informed and harm reduction-oriented resources that reflect women's lived and living experiences with chronic pain and prescription opioids. We were really fortunate to have 7 partners from BC, Yukon, and Northwest Territories that support diverse groups of women, including pregnant women, substance-involved, lesbian, senior, and Indigenous women. And we really were able to situate this project with women's voices and lived experiences. And you can see that as sort of the central bubble to the work that we're doing. In addition to those 7 regional partners, we also are lucky to have 2 national partners representing educators, including the Association of Faculties of Medicine Canada, in which I may refer to them as AFMC for short, and the Canadian Association of Schools and Nursing. And today we'll be sharing some of our projects from 2 of the project activities from this first year of this project, including a scoping review and interviews with women with lived and living experience. We're currently in the process of publishing the latter, so we'll share the recording with all the registrants following the webinar, but we'll be waiting to put the slides online. I'm going to pass it back to Liv, who's going to talk about the scoping review first, the part of the research evidence at the top bubble there, and then we'll move on to thinking through what we heard exactly in the interviews. So
the scoping review allowed us, through looking at extensive literature, to reflect on 5 key themes, which we're going to go through today. Stigma and the impacts of the opioid crisis on women with chronic pain, experiences of prescription access and desire for alternatives, perceived efficacy and risks of prescription opioid use for chronic pain in women, health effects, and intersecting consideration. It also allowed us to think about what information might be useful for healthcare providers. Okay, so here's the scoping review. Our research question was, what are women's experience with prescribed opioids in chronic pain? We screened 4,500 studies, which was extensive, and in the end, only 49 were relevant and included in our scoping review. The ones we did include were related to women's views, perspectives, perceptions, beliefs, attitudes on prescribed opioids for chronic pain or chronic pain condition. We also included studies on the misuse, barriers, drawbacks, benefits, side effects, adverse events, tapering, health effects, dependence, and efficacy as described by women. Now I'll move on to those themes that I mentioned earlier. So the first theme that we reflected on a lot was stigma and the impacts of the opioid crisis. The literature really demonstrated that the opioid crisis has put pressure on providers to limit prescriptions for opioids and reduce their current patients' opioid medication. This has greatly impacted women who live with chronic pain to access prescription opioids for pain management. For some women, it has been so hard to access opioids for pain management that they cited feeling overwhelmed and defeated by their pain. In a Canadian study, women using opioids described how their providers responded to the opioid crisis by universally forcing all their patients on opioids to taper without considering their individual medical history, pain level, or functional limitations. And this was particularly challenging for patients who use opioids as a last case scenario because alternative medications had not worked for them previously. Women expressed frustration and disagreement with the decisions made by providers to discontinue prescribing because of the influence of the opioid crisis and concerns of rising rates of addiction when many were using opioids to strictly just treat their pain. We found that overall, doctors being limited in prescribing opioids has created a strain on patient-provider relationship and trust. Additionally, women describe discomfort in their relationship with their provider because when they request pain relief, they are seen potentially as drug seeking rather than women in pain who are not receiving adequate pain management. And many women discuss understanding their practitioner's apprehension, but still found the limiting of prescription universally harmful to their experiences. And finally, if women did disclose their substance use histories with their doctors, many reported that doctors began treating them in a stigmatizing manner, claiming that their pain was related to their addiction. They received less investigation for their pain and were often referred to addiction clinics instead. The second theme further relates to prescription access as well as desire for alternatives. So as mentioned on the previous slide, women described varying and insecure access to prescription opioids to manage their pain. When women were prescribed opioids, some of them described receiving minimal information and guidance relating to pain management, plans, benefits, and risks, the importance of prescription adherence and side effects. In fact, some women describe being prescribed an opioid prescription and only learning after that it was an opioid because their doctor did not mention it during the prescription process. When an opioid prescription was revoked, women described that they were not given adequate alternative pain medication, which resulted in debilitating pain for many of them. Women experienced more trust in their healthcare team and in pain reduction when an integrative care plan was discussed. This includes a diverse care plan with things like physiotherapy, acupuncture, chiropractor, massage therapist, steroid injections, heat therapy, meditation, surgery, and much more. A third theme relates to the experience of using prescribed opioids for pain management. And how it relates to perceived efficacy. Women described prescription opioids as overall making their pain more manageable, helping them to numb the pain, supporting their return to day-to-day activities with less discomfort, and to be able to carry on with their day-to-day tasks. Some even stated that the act of simply being prescribed an opioid had pain-relieving qualities because they knew on their worst days they had support. Women also described perceived risks of taking opioids, such as dependence or addiction. Many women, for instance, were weary to take prescribed opioids due to a fear of becoming dependent and addicted, or being associated with a drug that is a source of addiction for many in light of the opioid crisis. Though uncommon, there were some women with chronic pain and substance use disorders who exaggerated their pain to access more prescription opioids to manage their substance use disorder. In relation to health effects, the side effects reported by women included drowsiness, constipation, memory loss, nausea, depressive symptoms, opioid dependency, and suicidal ideation. Women who were taking opioids were more likely to have more than one medical condition than men taking opioids. We also found that postmenopausal women with histories of prescription opioid use were more likely to have worse pain scores, increases in non-pain related medical conditions, lower physical functioning capabilities, higher BMI, and depression diagnoses. Women reported that often, when their physicians told them to go off of opioids, they did not feel well informed about how to taper safely without experiencing intense withdrawal and health effects. When women were asked to taper, some of the alternatives offered were over-the-counter products such as ibuprofen, naproxen, Motrin, acetaminophen, which led to effects such as damage to the stomach lining for some of these women. The last theme we found in the scoping review was relating to intersectional considerations and how women showed up in their bodies themselves in the healthcare. So The first one is relating to sexism. Women described that their pain was not adequately investigated before being prescribed an opioid and often after. Women reported worrying about the stigma they experience or would experience if their family and peers knew that they took opioids for pain management. Women expressed hiding their opioid prescription out of fear that they would be seen as bad or inadequate mothers for being on a prescribed opioid. In relation to colonialism, some of the Indigenous women in the scoping review reported wishing that parts of their cultural healing practices would be seen as legitimate aspects of healing and be included in a holistic care plan, but is often not seen as legitimate within our current Canadian healthcare system. As it relates to ableism, women reported doctors not believing they were in pain if they were able to walk or function semi-well. Some reported that their doctors claimed that women were faking it, or that if they were truly in pain, they would be less functional, which demonstrates an ableist assumption of the realities of the invisibility of pain, especially in many of the conditions experienced more by women, such as endometriosis, fibromyalgia, chronic fatigue syndrome, rheumatoid arthritis, and more. As it relates to racism, studies that included Indigenous women with chronic pain reported that they were less likely to have their pain taken seriously and to be seen as drug seeking if they were looking for a pain medication to monitor their chronic pain condition. As it relates to classism, women of lower socioeconomic status were more likely to be seen as drug seeking as well and to not have their pain taken seriously. Difficulties were described such as poverty, unemployment, and housing instability made the ability to make holistic lifestyle changes such as going for walks or eating healthy really, really difficult. Additionally, many therapies such as physiotherapy are paid out of pocket for individuals without insurance, and for many, this is really unaffordable. Women who didn't work also had or also felt a pressure to stay in precarious relationships to be provided for, which often left them feeling really helpless. So after all of this, I'm now going to pass it over to Lindsay to speak about what we heard in the interviews with women.
Thanks so much, Liv. I mean, there's so much data that came from these scoping reviews, and so much that we have seen. And so it was really helpful to have this further contextualized. And it was really interesting to see the extent in which our interview findings reflected what we'd also found in the scoping reviews. So last year, we furthered the work using the basis of the scoping review to really dive into what we were seeing in the Canadian context, and particularly with diverse populations of women and women that were recruited from diverse agencies in BC and the two territories in the Yukon and Northwest Territories. And so again, we were able to have agencies that were supporting pregnant, senior, lesbian, Indigenous women, women who use substances, and women with experiences of trauma and violence. And we recruited women in person and through social media, with a focus on purposively recruiting women from diverse geographic and social locations. We ended up interviewing 22 participants. So we had 15 participants from BC, and all of those interviews were conducted virtually. And we had 9 in Northwest Territories and Yukon, 8 of which were conducted in person and 1 was virtually. And throughout the interview process, our goal was really to capture women's experiences with chronic pain and prescription opioid use, including their experiences with prescription opioid use for chronic pain management, experiences when accessing continued care for pain relief, really gathering what women want to know and also what women want healthcare providers to know. And maybe I think it's really important to situate that, you know, we are researchers, we're also 2 people who experience chronic pain. And while we say all of this, we are not prescribers and we are not frontline providers. So I think that's just a really important caveat as we walk through these findings together. Our participants came from different backgrounds, and they were all recruited via those different agencies. Of those that explicitly disclosed their age, we heard from women 32 to 71 years old in those 3 provinces and territories. And there were 18 primary conditions reported specifically related to the prescription of opioids for pain management, but often women were not experiencing these conditions in isolation. So where, somebody might have been prescribed opioids for ulcerative colitis, they might have also been experiencing fibromyalgia, sciatic, etc. We also heard from women who used opioids for as little as 2 weeks and for as long as 24 years. And a third of our participants used prescription opioids for more than a decade. And 18 of the 22 participants had been using their prescription for at least 2 years. One of our first themes was really thinking through the benefits and harms. And I think it was really poignant, and Liv alluded to this in sharing the scoping review findings, was that despite concerns around dependency, women really spoke of the benefits of their use and how in many cases that outweighed the side effects and risks. For instance, we have this one quote here: "I think I shed a tear when I got some actual pain relief. Anytime I had a really good pain relief from anything, it's usually emotional, but in a good way. And I felt like I could do things. I felt a little high or drunk, if you will, a little bit. I didn't expect from it. Maybe a little off balance, but I was, oh, wait, I can do things. I can go run some errands and not be hating every second of this, but also, oh, this is good pain relief." And this was from a participant in BC with fibromyalgia, really emphasizing that their relief was about the quality of life. And again, echoing what Liv had said with the scoping review, that even when women didn't use their prescription, knowing that they had something that could help them walk, could help them spend time with their kids, be present physically, it was just so important to them. And it did outweigh many of the risks. We also heard the pervasive role of stigma. Given how much the opioid crisis was mentioned in literature, it really wasn't spoken about in the interviews or spoken about with such specificity. Rather, women often spoke of individual stigma rather than, the population effects or what's happening surrounding them. And it was often seen, prescription use was often seen as very private and surrounded by shame, guilt, and assumptions of others. And you see this quote here. "And what I find interesting within myself is that I loathe to say exactly what I'm taking, because not just because of the stigma, but I've had a bad result in thinking I could confide in a couple of friends. This is years ago, and it's, oh my God, you're going to turn into an addict," and basically them pulling back. And this was one of our participants that had been using their prescription or multiple different prescribed opioids for over 15 years. Women also spoke about how that stigma would impact their access to care. And I know Liv is going to speak to this in a few slides, but there certainly was a piece of this theme that also spoke to how practice wasn't necessarily relational or trauma informed, and perhaps experiences of women being in acute care settings, so being in hospitals when trying to access continued care, and being in severe pain, and rather than their pain being recognized and acknowledged, they were perceived as drug seeking. And beyond the interviews, from my own experience, I can see how that has been and can be the case. And one of our interviewees even said, not that we're out there trying to get everybody on it, but at the same time, take the stigma away. Liv shared this sort of honeycomb graphic of our scoping review. And again, we saw how women from different backgrounds described how their access to care was impacted by their race, their gender, the sexual orientation, age, class, ability, recovery status, and pregnancy and parenting status. For instance, many of the Indigenous women spoke about their experiences in both acute and primary care and how they were further stigmatized because they were Indigenous. And one of the interviewees even described a time in which a physician wrote in her chart instead of another First Nations client's chart, that if she were prescribed opioids now, she would access them illicitly on the street. And if it had not been for the extreme self-advocacy of this particular interviewee, that would have remained on her chart. We also heard from women who were in recovery from alcohol or stimulants, and that when they would continue or try to continue to access care, when learning about their recovery, their providers would either stop prescribing opioids or would move to an opiate agonist therapy. And so in one case, an interviewee who had experienced pain relief from Percocets was switched to Suboxone, and that actually increased her pain, but it also increased her concerns around dependency because she was starting to feel a high, and that wasn't something she had experienced with her Percocets previously.
So while some women describe positive patient-provider relationships, women also really describe the challenges of navigating the healthcare system, including the challenges of building a trusting relationship with their providers during competing healthcare crises. And a lot of women spoke about the importance of self-advocacy during this time, and they said it was really pivotal to accessing care and pain relief, but that not all of them had the privilege of being able to advocate for themselves in the way that their doctors were able to listen to them. But some of them were. A quote by one of our participants is, "My doctor was always apprehensive. I think she just didn't. She wanted me. She never was, hey, here you go, this helps. It was always, are you sure you want this? Is it working for you? Are you taking it on time or are you taking too many?" Yeah, she never liked prescribing it, but I was just, I don't know, I was probably combative. Well, I don't care what you like or what you want. It's my body. I'm in pain and this is what I'm taking. So that was just the opioids talking, I'm sure, convincing me that I needed it. And many women did speak about how they had to, when their doctors talked about tapering, that they had to question their doctors and say, well, what alternatives do you have for me? And oftentimes there weren't alternatives that were as helpful as opioids. And so they remained on them through themselves, advocating for themselves. So women use additional and alternate pain management strategies, including physiotherapy, chiropractic care, massage therapy, land-based healing, lifestyle strategies such as exercise, diet, supplementation, and other substance use, such as cannabis, alcohol, and illicit use. However, these were often described as expensive and out of reach. One of our participants said, "I did go to a pain clinic. They had a wraparound service. There was therapeutic yoga, all sorts of different things that was offered as part of their focus was less on opioid use and more on other meditation, whatever you felt worked for you. You could try all these things, and that's what I think every woman needs, is something like that."
And the last thing we really heard and spoke of was information needs. And I'll dive into this a little bit more, but I just want to situate with this quote. "I feel like there's so much information about not using opioids. I feel like there needs to be more information on how to use opioids effectively in healthy ways, almost like lower risk drinking guidelines, but not intended for street opioid use, but legit prescription opioid use and pain management." Things we heard from women about what they want to know are how to safely use and taper off. Many women didn't necessarily want to be continuing with their use, but it was effective for them, and they didn't necessarily have alternatives. Women want to know about the side effects. This was often not something that was discussed with providers. The potential benefits and risks associated with prescription opioid use, this again was not often a discussion that we heard of. The evidence on prescription opioid use for chronic pain and different pain conditions, as I mentioned, there were 18 primary conditions that were reported, and countless others that women experienced. And so trying to understand the efficacy for particular conditions, and really going through the mechanisms of not only that diagnosis, but also how sex interacts with that. And alternatives to use that are safe, affordable, regionally available, comprehensive. And this is just so important. I think it's something that many of us can take for granted is maybe we'll be with a provider and they'll say, well, what about a chiropractor? But that doesn't necessarily mean that everyone has access to a chiropractor. And I've just included here, this is a sheet from a toolkit we did a few years back called Mothering in Opioids. And this was a resource from women who were mostly using illicitly. And it was about what pregnant and parenting women who use substances would like practitioners to know. And I think it's just something for us to always sit with as I move to what women wanted providers to know. With providers, it was really about the relationship, the importance of collaboration, relationships that were built on trust and respect, understanding that every patient is different. So going back to Liv's comment about universally prescribing or reducing the prescriptions universally, really increasing knowledge about the potential benefits and harms of prescription use on behalf of providers, alternative pain management strategies, and that there are some advantages to opioid use. We understand that there are also many risks, but just thinking through those nuances. And I noticed one of the Q&A comments said, I'm threading the needle very carefully, and I think that's exactly it. It's really taking a sort of individualized relational approach that is so critical. And maybe while it wasn't heard directly in the interviews, we also heard about implications. And so as we wrap up, I know we're going to wrap up maybe a bit sooner than we thought today, which will give lots of time for Q&A. And we hope you put some questions in the Q&A for us, are just some practice and policy implications. And so maybe I'll start with policy. Beyond what we heard in the interviews, which, as I mentioned, I think really focused on individual or interpersonal interactions, we also saw some systemic challenges. And that included the impact of health policy on women's access to care, including prescription opioids for pain management. And that was also related to short appointment times, billing codes that were attributed, to one thing in that particular appointment, and the role of insurance coverage in ability to access comprehensive care. There was also the need for more family physicians and educators to have and be able to facilitate informed, non-judgmental relationship-based discussions. And of course, we saw the impact of the opioid crisis on prescribing practices. And I think all of these, emphasized why both SGBA Plus is critical in policy development, but also the need to have women's voices and their lived and living experiences reflected in policy and program development. And I will say it's been really wonderful to see the uptake of thinking through SGBA, but also understanding sex and gender science in AFMC's project response to the opioid crisis. And I have that up here on the screen, their faculty development tool. In terms of practice, we also see implications for providers on the front line. So thinking again, how we can engage in these trauma-informed, non-judgmental discussions, culturally safe conversations about prescription use and pain management. And these are really of critical importance. The resource that I have on the right here, this is from an earlier project called Doorways to Conversation, and it gave all of these ideas for brief intervention. And you can see here that one of the topics for discussion that might be relevant to your practice are talking through short and long-term effects, specific health effects, the effects of mixing prescription opioids with other medications, use and coping mechanisms, parenting, and of course, at the top here, prescription opioids is a component of pain management. So really thinking about how we can have these conversations that are not stigmatized and sort of open and allow for us to jump through these nuances and realities of women's lives. And we certainly see the importance of understanding women's perspectives and their reasons for use, so as to find options for pain management, whether it be prescription opioid for an acute or a longer term period, or alternate strategies. On the left here, this is a sheet that we created about talking about substance use. And in that case, it was specific to in pregnancy, but I think it's really applicable here that we can engage in these brief interventions that normalize the conversation. So that way it can be an open and honest, non-judgmental, non-destigmatizing conversation. Talk about supportive change, and that might include what lifestyle changes. That was something we really didn't hear, were lifestyle mechanisms that also could be embedded in pain management, personalized to that individual. So we are all in different life circumstances. And so recognizing that for some people, running might be really hard for them if they've experienced or if they continue to experience chronic pain, but it might be exactly what motivates them. And for others, that might be not a possibility. And so maybe a pool walk, or maybe stretching at home, thinking about women's lived realities, encouraging them, even having these conversations. They're really difficult. Certainly our findings reflected that even starting the conversation can be challenging, stigmatizing, at times adversarial. And so encouraging them for starting the discussion, thinking through next steps, and then checking in. Chronic pain is chronic. Continuing these conversations can just be critically important. And so I think there are lots of practice implications, and I hope that we can further explore them. As I mentioned, this project was really thinking through, or this webinar today was really talking through our findings from the first year. And we are so excited to announce that we have received another year of funding from Health Canada, continue this work. And so in this next phase, we hope to hold consultations and develop resources for healthcare providers, health educators, and health system planners on the evidence around sex, gender, equity, chronic pain, and prescription opioids, focusing on the implications that directly follow up the Canadian Pain Task Force and Action Plan for pain in Canada. And of course, we will continue to work with women with lived and living experiences to ensure that their voices and expertise are represented in all of the resources that are developed. In the next few weeks, we're also going to have a video on our website featuring Liv and myself talking a little bit more about this project. And so we invite you to check it out and continue to look at the project page that you'll be redirected to at the end of this webinar as we move into our next year of funding. We want to thank you so much for participating today, and we really encourage you once again to subscribe to our newsletter. If Ella hasn't put it in the chat, she will now. So thank you once again.